Do they have an office?
I do not know, and I think
Good afternoon, everyone. I think we're going to go ahead and get started. And unfortunately, our first vice president, representing Douglas County, Nebraska, Marianne Morganson, couldn't be here. So I'm going to substitute for her, and I'm going to try to make it through all of this since I haven't read too much of this before now. But thank you. This is a great turnout. I'm Nancy Sharp, Arapahoe County, Colorado Commissioner, and I chair the Human Services and Education Steering Committee for NACo. So today, in partnership with the National Association of County Behavioral Health and Developmental Disability Directors, we're hosting this briefing on behalf of the nation's 3,069 counties to educate federal policy makers on the county role in providing health services to justice-involved individuals. I'd like to first thank Dr. Mansharai, Executive, probably messed that up, Director of NACbid for his partnership in organizing this briefing, and NACbid's leadership in coordinating our efforts in educating Congress and the public on this subject. I'll also speak on behalf of NACo's leadership when I say that we're excited to stand before you today and here to speak about this issue that's so critical to counties. I'd like to set the stage for our conversation this afternoon with a brief overview of the county's role in the criminal justice system and our responsibilities related to healthcare services for individuals in our custody. As you may know, county jails are the entry point into the criminal justice system. Counties invest nearly $200 billion a year in justice and public safety services and community health systems. More than 10.6 million individuals across the country are admitted into 2,785 county-operated jails every year, and the counties are required by federal law to provide adequate health care for these individuals due to the 8th Amendment in the U.S. Constitution. From the moment an individual is booked into the jail, they are unable to access their federal health benefits despite being pre-trial and still presumed innocent. That's due to what is known as federal Medicaid inmate exclusion. Here to talk more about this policy and its impacts on counties and NACo's efforts and to address this issue is our panel, and I'm going to moderate and turn it over to them in just a few minutes, and I'll introduce them. I am really appreciative that to be asked to co-chair this new task force partnership with NACo and the National Sheriff's Association. At yesterday's general session, NACo President Greg Cox announced these two organizations in partnership with county officials representing judges, prosecutors, public defenders, public health, and veterans services will explore the impacts of existing federal policy on recidivism and health outcomes in our jails, on our jail inmates, and with particular focus on individuals suffering from mental health, substance abuse, and other chronic health illnesses. Across America, when an individual is booked into jail, they lose access to their federal health benefits, including Medicaid, Medicare, and for juveniles, children's health insurance plans and veteran benefits, even though they are presumed innocent. This truly puts undue hardships on our local judicial, public safety, and human services systems. It can also result in higher rates of recidivism, even though that's what we're trying to combat today, and human services. Increased healthcare costs, poor health outcomes for Americans. This policy also drives the over-incarceration of those suffering from mental health and substance abuse, as county jails have become the largest behavioral health facility in the nation. Today, we'll hear from our three panelists and county leaders will provide local perspective on this issue of national concern. Okay, and we're also going to be joined by Representative Paul Tonko. He's going to drop in, so if we stop and hear that he's going to be coming, I'll kind of stop the presentations and we'll have a chance to introduce him and hear from him. He's representing New York's 20th District. So it's my pleasure to introduce the Honorable Errol Toulon, who serves as County Sheriff for Suffolk County, New York, and the Honorable Helen Stone, who serves as County Commissioner in Chatham County, Georgia, the Honorable Rick Sanders, who serves as on the Board of Supervisors for Story County, Iowa. And with that, I'm going to turn it over to Sheriff Toulon.
Thank you, Commissioner Sharp, and thank you for moderating this event. I'd also like to thank NACo for hosting this, and also my fellow panelists. I've been a sheriff for almost 15 months in Suffolk County. Prior to that, I was the Deputy Commissioner of Operations with the New York City Department of Correction for 25 years. I started as a correction officer in 1982. In 1982, when I became a correction officer, one of the things that I heard inmates telling me was the fact that they would get arrested in the wintertime, specifically to avoid homelessness and the streets of New York, because they didn't have any place to go. Jail was their only refuge. Now in 2018 as a sheriff, inmates are telling me that they're coming to jail for health care because they cannot afford it, they don't want to burden their loved ones. And so this is becoming a huge, huge issue, not only throughout this country, but for the counties. The counties are absorbing this tremendous burden of health care for inmates who are incarcerated. Jails across the country are becoming the largest behavioral health, in addition to treatment for those who are substance abusers, and now slowly becoming medical providers to many individuals who seek incarceration as an option to health care. In Suffolk County, the Sheriff's Office is the largest Sheriff's Office in Suffolk County, and only second largest jail behind Rikers Island in New York State. And that's with jails, that's not prisons. Our Suffolk County Health Department is the department that provides health care for our inmates. The Sheriff's Office does not have the sole control over health care that's provided to the inmates, nor do we make decisions for them. Our inmate population on average is 1,180. Last year, in 2017, we saw 4,100 inmates in our clinic. 4,100 inmates in our clinic in 2017. And of course, they're provided with emergency care 24 hours a day, 7 days a week, dental, pharmaceutical services, vaccinations, contractual podiatry, laboratory, x-rays, sonograms, and also AIDS counseling are the types of treatment that they receive. Just to give you a snapshot of our facility, as of last Monday, I had 9 inmates over the age of 70. I had 36 between the ages of 60 and 69, 62 between the ages of 55 and 59, 84 between the ages of 50 and 54. We're facing an aged population in our facilities. We had approximately 130 females. None of those female inmates had babies or infants in our infirmary, and about 230 between the ages of 18 and 25. And 2/3 of that population that we have are pretrial detainees. We had to establish a senior pod for those that are 55 and over, not only just for their health care needs, but so that they can better acclimate into the prison system so that they're not in a housing area with 18 and 19-year-old young men. We're working hard with our incarcerated veterans, not only because of the signs and symptoms that they've acquired defending our country, but the homelessness, the lack of employment opportunities that they've received. And this cost of health care for incarcerated individuals is becoming such a financial burden, not only to the counties, but constituents within that county. And so I wholeheartedly support having the access to federal health benefits to those inmates who are awaiting trial, especially for those who have their constitutional rights because they have not been convicted of a crime. Having access to the federal benefits for non-convicted individuals would also allow for improved coordination of care. You know, I've encouraged inmates and I've encouraged the medical staff, and this isn't something within my purview, to reach out to the healthcare providers who previously provided healthcare to these inmates, so that we can know exactly what the treatment was, what were the prescriptions. You know, we can only go by self-admittance as to what these inmates tell us, and then a medical diagnosis or mental health diagnosis of the healthcare professionals inside of our setting. And then finally, providing access to these federal inmates, the federal benefits for those awaiting trial and verdict decisions would help the counties help break that cycle of recidivism. You know, if we can continue to treat them with their mental health issues post-incarceration, is something that I feel that us as society needs to do, because I think that breaking that cycle and assisting them, whether it's employment, when we're talking about, of course, healthcare, is something that's very important, because these are the same individuals that I tell everybody when they transition back into the community, they're in front of us or behind us at Target, Lowe's, in the supermarket, and if we can continue that healthcare, you wouldn't want someone with serious mental health issues that have been off the medications, or someone has a chronic ailment that has not received treatment or not received the necessary medication, to go undone. Thank you very much.
You can go up there or whatever you, I think maybe people can see you a little bit better.
Those were some pretty alarming statistics. My name is Helen Stone, as you all probably saw, and I am from Chatham County, Georgia. And Chatham County is the home of one of Georgia's largest population of the coastal region in the historic city of Savannah. Approximately 2 years ago, several elected officials and I toured the mental wing of our county detention center. We were standing in the middle of the pod, gazing into one of the units, and I spotted a young man. He was sullen, he was broken, and he walked forward to a yellow line with weighted shoulders. In his hand, he clutched some papers, and he stood there and he looked up, he looked sideways, he looked down, and Judge Friesman, who was standing next to me, turned to me and said, "Do you know what he's doing?" And I said, "No." She said, "He's standing on that yellow line because that's as close as he can get to us. And he thinks that this group out here is willing to help him." Who was he? Why was he here? Where were his relatives? And who was going to help him? Who? Why is the federal government taking away Medicaid before he has been proven innocent or guilty, thus making it harder and more burdensome for him to get the help that he ultimately needs? I have been fortunate enough to have served on the Chatham County Commission for 14 years, and I'm honored to serve on the National Association of Counties Health Committee. A portion of the Health Committee's basic philosophy includes the statement: at the most basic level, county officials are elected to protect the health and welfare of their constituents. It further states that county governments often serve as the payer of last resort for the medically indigent, including our veterans. County jails must offer their inmates health care as required by the United States Supreme Court. The Chatham County Detention Center, the Sheriff's Department, and our courts consume roughly about 48% of our annual operating budget. And yes, I said 48%. Thus, about a year and a half ago, Chatham County initiated a program modeled after the National Association of Counties, their Stepping Up initiative, but ours is known as Breaking the Cycle. Our mission is to reduce the recidivism rate for adult offenders through an array of strategies focused on individuals with mental illness, to include reduction of number of people booked into the jail, number 2, shorten the length of the stay in jail, and number 3, increase the percentage of individuals with connections to care, and that's extremely important. Goal number 1, which is really a diversion, to reduce the number of people with mental illness entering our jail. We had to increase our crisis intervention training, and I don't know if you all know what that is, but it's a wonderful program where it trains officers to help de-escalate situations that they encounter. At this point, we trained about 350 officers, and we have 9 new training opportunities in the forefront, and we want to add another 250 officers. The City of Savannah received a grant, a $790,000 grant, for a mobile crisis response behavioral unit, which allows licensed clinical staff to respond to a call and to provide follow-up. Again, key. Our newly elected governor of Georgia, Brian Kemp, announced the launch of a new mobile app that offers free and confidential access to people suffering from mental illnesses and substance abuse. And this next thing I'm very, very proud of. Our Breaking the Cycle team, in conjunction with the County Commission, the staff, and I have 2 staff members here today, our 2 assistant county managers, Linda Kramer and Michael Kegler, and with their help and the Department of Behavioral Health and Disabilities, we will be opening our Behavioral Crisis Center in 2019. This will be a 24/7 standalone facility with 24 crisis stabilization beds and 6 temporary observation beds. And again, this goes back to the diversion. We don't even want these individuals to get to jail. We want them to get the services they need, and so we don't have to worry about whether their Medicaid is going to cover their expenses in the jail. Our goal number 2 was to shorten the length of stay in the jail. And these numbers were a little bit alarming. We had to strengthen the referral process from the mental assessment to treatment and work with the judicial system to reduce the number of days for inmates awaiting a forensic exam. Now listen to these numbers. In 2015, people were sitting in there for 325 days. In 2016, we got it dropped to 210, and in 2017, we're down to 74 days. In addition, under the leadership of our sheriff, John Wiltshire, the Chatham County Detention Center has been the first jail accredited for mental health standards per the National Commission on Correctional Health Care, and we're extremely proud of him for that. Goal number 3 was to increase the percentage of connection to care, and this is so important if you are looking to reduce your recidivism. We had to implement a behavioral health transition support staff at the detention center, which has been done through some of the funding through the Georgia Department of Behavioral Health and Gateway Behavioral Services, which provided a transition specialist to work with the detention specialist staff to connect the individuals being released to the services, such as the additional community-based resources, as well as tracking for ongoing follow-up. This data is important because if you don't have the data, you don't have anything to compare it to. So we still have some challenges. Our challenges are if their Medicaid has been revoked, the individual must reapply to get their medication. They leave the jail with a 5-day supply. What happens when they run out? You can't get your Medicaid reinstated in 5 days. What do you think is going to happen? They're going to recidivate, or there are going to be problems. We need more training for our 911 operators and response teams. We need a system analysis for data. Again, data. And if we operate in silos and cannot share this data, it's not going to help the judicial system, help the jails, help the individuals. Continued support for enhancement and expanded of staff training. That's always important. And we need support for an additional licensed professional counselors and a psychiatrist to be on site at the detention center. Currently, we only have a part-time staff member, part-time psychiatrist out at our detention center. So I don't know if that helps, but it's very important to us to try to help those who cannot help themselves. And I'm so honored to see my congressman here, Buddy Carter. Thank you so much for stopping by, and thank you for your assistance. Now, if you will just help us with this Medicaid, I would really Rick, you're next.
No pressure.
Well, hi, good afternoon. My name is Rick Sanders, and I'm from Story County, Iowa. So I get to give you the rural perspective on all of this, and I think that's the reason that I was invited. First, I'd like to say, wow, what a spectacular turnout, and thank you to all of you for being here so that we can discuss this important topic. So Story County, Iowa is right in the center of Iowa. We're about 100,000 people if you include our 36,000 students at Iowa State University. Also, many of you probably tragically got an opportunity to read about us with the death of Thela Barkley, the female golfer who was tragically murdered this fall. Actually, the gentleman accused of that is sitting in our county jail right now. So we are a much smaller operation than anything that you've heard about to this point, but its impact on our ability to serve our residents is every bit as dramatic as everything that you heard. This is a vital issue. We have more than half of the inmates who reside in the Story County Jail have some sort of mental health issue. About 85% of that are co-occurring with drug and substance abuse. And when they come to us, it falls 100% to Story County residents to pick up the tab, even if they're only charged of a crime. Which by the way, and I'm sure that most of you in here know more about this than I do, but doesn't that just sound like the opposite of what it's supposed, innocent until proven guilty? Isn't that the opposite, that you're losing rights and benefits because you're charged with something before you're ever found guilty? The impact to us is we have seen our costs at the local level more than double in the last 10 years when it comes to provision of law enforcement and jail services and human services. This is something that absolutely cannot continue. We are in a crisis, especially in rural America, but I think all across America with mental health issues and substance abuse issues. And if we're counting on our county jails to become our largest health centers, our largest centers for mental health services, we're doing everybody a disservice. We can't afford it financially, and it's not the right thing to do with our citizens. Again, I'm so appreciative to all of you for being here. To any members of Congress who happen to be wondering, we need your help on this. This can't be the intent. When this law was passed, this can't be what was intended to happen, and its dramatic impacts on all of us, all the way down the line in government, I can't be overstated. Thank you very much.
Okay, now we're going to have time for about a half hour of questions, and who has some questions? Gotta be some questions here. Yes, ma'am.
You had mentioned data as being very important and tracking data, and I'm just curious to know, actually from anybody, but specifically you, Sheriff, if you could tell us about systems for sharing data between different stakeholders in the criminal justice system in your county.
So let me just make sure the question was about data and sharing data.
So I'm not going to lie to you that I have a very difficult time with our health department with certain data because of HIPAA violations. it's to have a true partnership when we're talking about the healthcare. The men and women inside my organization, the corrections staff, are charged with 24/7 care, custody, and control. And if an inmate, of course, requests to go to the clinic or see a medical provider, we will get them there. But my correctional officer doesn't know what other signs and symptoms they should be looking at. Because if they're, of course, if they're suicidal, we're going to know because they'll recommend that they go into a separate housing area with a more observation watch, where we may have a one-on-one with them. But that true data sharing, even if some information was redacted, would be extremely helpful for us. Now, just to hopefully prevent an incident with an inmate on staff, or self-harm.
I share your concern. We all have a tendency to operate in silos, and we don't seem to want to share critical data that could help individuals get processed through the system quickly. We could have a better understanding of who we're dealing with and what problems may have been in their past and how to best treat these individuals.
Yeah, so I would just say from our perspective, especially at the rural end, we try to view any visits to our county jail as much as an opportunity to make contact with that individual and make sure that they are being directed to the services that they so desperately need. And so we've actually started doing, at the beginning stages of doing a reasonable job of communicating with all of our service providers to make sure that as individuals are coming to the county jail and ultimately leaving the county jail, we don't ever want to see them again. And one way that we can help with that is make sure that they are connected with the right services and right entities in the community. And so we've really started to make a concerted effort along those lines.
Yeah, Commissioner Stone, you mentioned accreditation in your jail, mental health accreditation. Can you elaborate a little bit more on what that is and what you did to have that happen?
I didn't do anything. This really was our sheriff, and with the backing of our county staff. And he recognized the issue that we were dealing with the mentally ill early on in his administration, and he wanted to help address this problem as well. I mean, everybody knows that county jails have become the largest providers for mental health.
Would your sheriff be the person to talk to about the process that
Absolutely.
they went through?
And I'd be happy to help connect you to him.
Thank you.
So maybe we can make that available through NACo to the contact. This question was, which I think it's a great question for accreditation on mental health, because we may have jails. I know our jail is accredited, but I'm not sure how to become accredited for mental health issues. What do we need to do?
And this has only been within, Linda, the last 2 months? 3 weeks. Few weeks, okay. So it's very new.
Okay, so we'll get some additional information. Yes, sir.
One of the issues, I come from a law enforcement background, and mental health and mental patients in jails is a big issue. Well, we interdict with mental patients all the time as police officers. The case from 1973 actually came through the city of Milwaukee, went to the Supreme Court, the doctrine of harm to himself or others. So most of the time, when we interdict with these mental patients, we're unable to get them to the services they need because we can't force them into what we call in Wisconsin Chapter 51. We need to, before they get to the jails and come to a problem, we need to look at legislation to change how we deal with our mental illness before they commit acts. I know as a police officer, I ran into people that they shouldn't be on the road. They shouldn't be out on their own. They should be either medicated or they should be under the care of a physician or they should be in place, okay? And they don't belong in a jail. And I can say for myself that there were a number of these people that were interdicted with police, ended up committing crimes and became inmates. And then they become a problem in the system. I think if we get that before it becomes a problem into the system, I think that's where we need to go. Now, in Georgia, how do you get those people into those beds? Are they already been arrested and then you divert them to that, or how do you manage that system?
We are opening this diversion center in 2019. We are just getting ready to break ground. So that is hopefully going to give our officers an alternative of where to take individuals that are showing signs of mental illness or substance abuse, because sometimes they're intertwined. So that we want to prevent a low-level offender from even entering the jail. Because here again, once they enter the jail, and if they're booked, their Medicaid is taken away. So if they don't even have to be booked into the jail, then you can provide the services and they have their Medicaid. So it's a win-win situation.
Have there been, do you envision any legal challenges to that? Because one of the reasons that law was passed was to provide for the citizens' rights to be unduly, have their rights taken away from them with a mental illness placement or forced placement. That's something that I can see that becoming a problem if it's not a voluntary thing. If people can volunteer and they can sign themselves out immediately, you're running into some issues where how do you get that person placed without a criminal offense first? But we want to get them placed before they commit the criminal acts. It's kind of a catch-22 situation.
It is my understanding that it would be a voluntary situation.
Okay.
And most people, I think, and I'm not in law enforcement, and I do not want to be perceived as if I am. If someone is picked up by an officer, the majority of the time, unless it's a hostile environment, they will cooperate, especially with an officer that has gone through the CIT training and understands how to de-escalate situations. But no, if they go to the diversion center, we have no means to hold them there for a minor crime unless they're being prosecuted.
Thank you.
So in Story County, we just, in October, we opened what we call a crisis care stabilization unit. It's a partnership with our local hospital. County built the building, owns the building. The hospital is providing the services, and what it did for us is it filled a gap. So we had at the hospital, if you were committed, there was a place. If you committed a crime or there was nowhere else where you could go to the county jail. We wanted something that was neither one of those, more voluntary in nature, but to give an opportunity to de-escalate the situation. Our sheriff, Paul Fitzgerald, does a phenomenal job requiring all his officers to have mental health first aid training to try to identify issues, and then we have a 24/7 crisis response team that can go out, hopefully de-escalate whatever situation you have, but now with one more tool in the toolbox that doesn't escalate all the way to incarceration, we feel is beneficial.
I know in the human services area, you have kind of the same issue in adult protective services. So when they're an adult versus a child, it's a very different situation. And what our authority is as police officers or in the human services area, it's complicated, yeah, for sure. Questions? Anybody else?
I just wonder if any of your counties or states are addressing also the issue of posting bail, because if people are often kept in jail because they can't post bail, and so if they were able to not have to post bail and maintain recovery, that would be one way to address this in the short term while we take this other initiative to try to get the federal law changed. So I wonder if any of you have been addressing that issue.
So there is a cash bail initiative that's been spoken about in New York State, and until that's passed, we in Suffolk County do not have anything else in place. You know, at one point we discussed having bail expediters, where if an individual had a $500 bail, we'd have these expediters contact family and friends that may be able to put up portions of it so the sum would equal $500 and then assist in getting that individual out. But nothing as of yet.
The closest we come is our fantastic county attorney has really worked hard to put together both a mental health court and a drug court. And if the judges are willing to participate in those, it's so it's not a direct answer to your question because it doesn't directly deal with the bail issue, but if we can get them into those processes, we seem to be able to move a little more rapidly and with a little more leniency might be the wrong word, but a little more opportunity of trying to fix the issue rather than have somebody pay for it.
Our state legislature in Colorado is taking up that issue to see if there is some sort of sliding scale based upon ability to pay that could be fairer to those people coming into the courthouse or the court system.
You know, when I was a young correctional officer in the 1980s, around 1988, 89, we had 25,000 inmates in the custody of the New York City Department of Correction. So much so that Mayor Koch implemented a 10% bail reduction. So if you had $2,500 bail, you were able to pay $250, you were released from our custody. But that was during the height of the crack cocaine epidemic in New York City. And so unfortunately, as quickly as people were leaving the jail, there was someone always coming in right behind them.
Other questions? Yes, sir.
Commissioner Stone, you mentioned that sometimes it'll take up to 5 days to get an individual's benefits reactivated.
No. I said that when they leave the jail, they are given a 5-day supply of medication. And that certainly, you cannot get your Medicaid reinstated in 5 days. So you have an individual that's on medication, now they're off the medication. So ultimately that's just gonna lead to problems and possibly recidivism or even sometimes larger, problems when someone is in need of psychotropic medication and they can't get it. You can let your mind wander where it goes.
So is jail staff reactivating the benefits or starting the process before the release?
We are looking at starting where some of these trained folks are coming in 30 days ahead of their release and trying to help prepare them. But that doesn't always, it's not a guarantee that when they walk out with their 5-day supply that the Medicaid's gonna pick right up on that 6th day. It's better just not to have it revoked at all.
Back here.
Question for the panel, starting first with Mr. Sanders. Anything helpful or interesting to add related to the dually diagnosed population for mental illness and developmental disability?
Can everybody hear that over here? Okay.
If it's even on the radar screen, I recognize it's a pretty narrow subset.
Yeah, so I'm trying to think of somewhere that I could speak to something specific that we would do differently, and I don't have anything that comes to mind that we would handle differently with the developmental disability.
And I'm not in that field, so I'm gonna pass it on.
You know, we would work with the courts to find not only the necessary housing, but if the courts deem that the person should not be incarcerated in a correctional facility, we will move them to the appropriate facility.
I think it was previously mentioned about women. I'm curious to see what exactly is the situation with yes, medication, but what if you have an inmate that is pregnant and what type of services are provided or connections are done for the new mother that might be leaving the jail or going to prison afterwards?
So, if I heard your question correctly, if a female is incarcerated and they are pregnant, they will be put in special housing. They will receive the necessary services by the medical staff. Once the female gives birth, we have a nursery where they will be able to spend time with their baby one-on-one for almost a year. If they're moved to Bedford Hills, which is a state facility in New York State, the baby and the mother will be transferred to that facility if the mother chooses so.
So what happens, I know that one of the big issues that we're discussing is that Medicaid or Medicare might be cut. So what happens if, say, the mother actually leaves jail? Is there still that issue about not getting the Medicaid potentially for mothers and babies?
Good question. And I'm sorry, I do not have the answer.
Okay.
Anyone else? Gotta be a lot of questions, there are a lot of people here. So I just have a question, how many people here are gonna be serving on this task force? Do we have people here that are gonna be on that? Raise your hand. Okay. Well, got a list, and I would suggest that, I'm sure, Matt, that'll be on our NACo website. And so connect with anybody that you see on there from your county or state that you want to make sure that your ideas or concerns are something that we consider as part of this task force. And yes, go ahead.
Question for Mr. Sanders and Ms. Stone, in terms of the facilities that you mentioned, one hospital and you and the other one, who's funding those centers? Yeah.
Ours was a joint effort with the state of Georgia to build the actual facility, and the funding is coming from our Chatham County government. Because we feel like the money that's going to be saved on the front end here will more than compensate for what we're paying currently.
Yeah, so in our case, the county funded the construction of the facility, outfitting of the facility. The hospital agreed to take on the personnel services and all licensing and everything. And then in Iowa, we have mental health region. So Story County is part of an 11-county region, and where federal funding is not available, the region will pick up the funding of the actual provision of services.
We've got our guest coming and just is on his
Coming
way.
off the floor right now.
So, great. So, I just wanted to say in our county, in Arapahoe County in Colorado, we spend about $1 million a year on healthcare benefits for pre-adjudicated inmates. So it's a very significant amount of money, and we want to make sure that that they get these individuals get all the services that they need. And while I'm just waiting here for a few minutes, I'm just going to say, talk about that. Our work is going to continue to educate our congressional members on the importance of reducing jail inmate recidivism through this continuity of healthcare services. And it's been an issue, but it's really come to the forefront now more than ever. And so we've just started this process, and NACo is going to continue to advocate on behalf of counties by requesting that Congress make allowances for continual access to these federal benefits, and Medicaid, Medicare, CHIP or Children's Health Insurance Plans, and veterans benefits until the individual is adjudicated. And I think it's only fair to those individuals, and it's the best thing, and for us in the county, since we are picking up a lot more of the cost and responsibility we have a responsibility for jails, and it's now become our responsibility for handling a lot of mental health issues in the county, and how do we best handle those and work with those individuals. So I think it's it's a difficult thing, as we were talking about earlier, when somebody refuses services, and how do we do that? I know we're also going through a what's called in Colorado a red flag bill. So individuals with firearms that have a mental health issue or perceived mental health issue, can you take their guns away? You know, those are the kinds of things. They're an adult, and who determines that, makes that determination or not? It's a very tricky thing, and it's being debated in our legislature now. And what steps over the line, and what protects that individual and others who might have mental illness. So I think I'll just speak for myself and for our other task force members, and hopefully for the National Sheriff's Association, that will be dedicated to organizing these advocacy efforts, and it will be really important to hear from you. Yes, sir.
So I live in a much smaller rural county, and I also operate a retail independent pharmacy, and I was really curious that 5-day number you talked about with dispensing medicines with Medicaid. Is there any data behind how many people are denied service at a pharmacy because their Medicare or Medicaid is cut off? Or is there a way to track that? Because that's something I never thought about as a pharmacy owner. Like, what do? I live in a rural county with the only pharmacy. What do I do?
I certainly don't have that data. I'm just talking about what they leave the jail with. So that's provided as they're leaving. So I don't know.
I was just curious.
You know, we are fortunate enough in Chatham County to have a safety net program, and indigent and low income individuals can enroll in one of our safety net providers. We have 3. And certainly get their drugs, their medication at a reduced price.
Thank you.
I represent a community mental health center in rural northern Michigan. And actually, I'd like to ask a question about the drug formulary. Some of the problems we have encountered with our local jails is that a person is released from an inpatient psychiatric unit, certainly with their prescription, and then eventually they end up in jail, or they go from the hospital to the jail. The jail will not accept the drug, the prescription that comes from that hospital. They have a different formulary, or they don't want to cover that. We know there's a wide range of cost in all of that. And I think that's a part of this as well, because they come from the hospitals, have found a prescription or formula that will work for them, but then they go to another setting and it gets changed or it's not accepted. And you know, how do we rectify that? How do we help the person keep that continuum of care to keep them safe and keep them at a level that they need?
You know, that's an excellent question, because I've heard inmates talking to my staff about that. Upon admission, they'll be prescribed a medication that's generic to what they might have been previously receiving. But I think part of it might be just educating the inmate to let them know that it's still the same dosage, it's still the same prescription. It's just maybe a different manufacturer. So I think part of it has to be the education of the healthcare provider or whoever's issuing that prescription, to inform the inmate, to really allay their fears of getting something different that they feel may not be appropriate for them.
We're going to stop for a second and welcome Representative Tonko. I want to give you a mic here. I'm going to introduce you. Hopefully I'm speaking loud enough. Congressman Tonko serves the House Committee on Energy and Commerce, which has jurisdiction over public and private health insurance. Here, put that over here.
Sure, thank you.
Okay. Public and private health insurance includes Medicaid, which is now partially funded and administered by counties. Congressman Tonko has a long track record of making mental health a priority and has continued his efforts in the whoops, I turned that on. I probably hit the wrong button. Has continued his efforts in the 116th Congress with the recent reintroduction of the Medicaid Reentry Act, a bipartisan addiction treatment bill specifically targeted at individuals who are
incarcerated. Thank you so much
My
for
pleasure.
being here.
My pleasure. Thank you. Thank you, everyone. Good afternoon and welcome to the, I don't know which mic is, they're both working? Whatever, there's something's working, so thank you. Let me first welcome you to the Hill. I think it's so important to see this kind of visibility on issues that pertain to counties, certainly, and to behavioral health. Let me acknowledge Jeff Morgan, who I thought was in the room. There he is. Jeff, step forward so I can just say thank you. Jeff's not only our legislative director, but he had done health policy before he assumed that position and retains that assignment. So I want to thank him for the awesome work and the passion he pours forth for what are critical issues that deal with not only healthcare in general, but also including mental health and items that are correlated like suicide prevention and the illness of addiction. So I thank you, Jeff, and publicly it's a pleasure to acknowledge that I have coworkers that really care about public service and pour forth every bit of energy and intellect to make a difference. Let me welcome all of you here. Thank you for co-hosting this event to the National Association of Counties. Steve, it's good to see Steve Alessio here, a longtime friend who leads the effort in New York. Thank you for your work, and also to the National Association of Behavioral Health and Developmental Disability Directors. Thank you for the work you do. Thank you for the compassion that you bring forth. There's a little known secret, perhaps, that I started my elected career at the county level way back in the 70s, which makes me a dinosaur. But I served in 4 wonderful terms at the Montgomery County Board of Supervisors, and I've always enjoyed the legislative branch of government for the many reasons that that career embraces, especially public policy development and being able to serve as an advocate, working with the general public out there to strike policy that speaks to the needs of this country, the state, or the community we call home. But I think what I would acknowledge here also is that while I enjoy the legislative branch, it was that local level that taught me that that branch and that location along the way is the pulse of the people, that you are there as a frontline bit of stewardship, and that you provide for the sense of reality for so many people. And so I thank you for that. Obviously, with this group here joined together as work that is done at counties and local levels, it's important, I believe, to be able to recognize that when we have crises at hand, we have to do the common sense thing. And we have to make certain that we invest resources and that we put our thinking caps on and respond not just with what is common sense or intellect at some junctures of the way, but it's also to be there and provide for the human face and the name. So many times we get trapped in what is a ledger or accounting exercise that really doesn't tell the stories about people who struggle. And I would hope that we all see this arena as one that enables us to be there in the highs and lows. That's the beauty of government. We're there as people need assistance. We're going to provide that assistance, again, hopefully with great wisdom and a heart and soul for the matter. It's what drove me with these crises that we have. I'm a member of Energy and Commerce, but before I got on the Energy and Commerce team, serving as a state legislator in the state of New York, it was my involvement with a constituent who drove the mental health parity legislation that was the first in the nation, preceding the federal response and any other state capital in the country. I'm proud of that fact, and it came because someone shared a story, albeit painful, where they lost a son at about 12 years of age, who had tremendous health response for his mental illness and his mental health disorders. He was triply diagnosed, but when he hit the pit, when the caps were reached, life wasn't good. And Timothy gave up on his struggle. And it says his family taught me he completed suicide. He completed suicide. If there was any committing of wrong, it was by a government that didn't understand his struggle. And so I learned much from Timothy in his life and in his death. I promised to his family to work to my nth degree to drive parity as an issue so that no family would ever have to face that again, at least in the region that I could make a difference in, the state of New York. And after that, quickly after that, the federal government moved, and now many states have moved. But it's the right thing to do, it's the compassionate thing to do, and it was driven by a story, real life. And so today, we are tangled in a tremendous crisis, or might I say crises. Mental health crises, behavioral health crises, and certainly that of substance use. And none highlights it better, or more tragically, or more poignantly, than that of the opioid crisis that faces us. The time to put on our thinking caps, and the time to really think outside the box, and the time to connect with the families who walk this walk. All lives matter as we go forward. And if there are those who are incarcerated, those lives should matter. When we want to do things smart and intelligently and do it most cost effectively, we look at where we're falling short. And if we know that 129% is the chance, the greater chance of succumbing to overdose in the first 15 days after release, ought we not look at policy that will respond to that? We know we can make a difference. We've seen where situations have been worked, where jails have become progressive, incarceration centers have created units within their structure to respond to this illness of addiction. Much of it coupled with mental health issues, mental illness, mental health disorders. And so what we did was look at the statistics and understand that if we can spin up Medicaid for those who are qualified for Medicaid, which is the case for many, we know that it's been a terrible saga for those who are introduced to the incarceration centers. It shouldn't be that we warehouse people. It should be that we give them hope. There's no greater commodity for government to produce in the lives of people. And so the hope that we can produce is to determine at that point of a release date established to initiate the Medicaid medication-assisted treatment 30 days before release, so that then that person can have a strength as she or he leaves that center. We know that within 15 days after that release, if that doesn't happen, it's 120% more likely that that person will succumb to the illness of addiction. And so it's a good use of dollars atop dollars to make certain that that person leaves that center tethered to hope, understanding that perhaps it was a physiological adjustment that came during the term of incarceration that makes that individual a greater risk. You know it, the behavioral scientists in this room know it, that there are tools we should have in the kit. And when government is just totally recalcitrant in the approach, when they might suggest by their actions, maybe not their words, that some lives matter, but not all lives matter, that's not good enough. All lives matter. And some of the people, some of our neighbors who are incarcerated, those who in all income strata are fighting this illness of addiction, there go I. For the grace of God, it could be any of us. We've seen how this has gripped our society. So let's get smart. I've introduced legislation again, reintroduced it this time in a bipartisan format, as we did last time, with Representative Mike Turner from Ohio. I don't know if we have any Ohioans in the audience. We do. Okay, shout out for Ohio, without any charge. Okay, so we partnered with our friend from Ohio, our colleague, and we introduced the bill. Jeff, is it 1139?
Sorry.
What's our bill number?
1329.
1329, thank you. 1329, HR 1329, which will give people a shot of hope when they most need it. Shouldn't we be about making life better for our friends, our neighbors? Shouldn't we be about making it better for people who share a common county, knowing that they're facing such a difficult walk in life? So that's our message here today. I say do it with boldness. Don't tell us don't let us tell you there aren't the resources to make this happen. Don't tell me we've got to cut Medicaid and Medicare and Social Security. We found a way to spend for a tax cut that helped the wealthiest corporations in the world and the wealthiest Americans amongst us. So if we found that money, There should be money for our brothers and sisters who are most in need. And we can do it in bold fashion with a great heart, a great soul, and a mindset that tomorrow we will deliver a brighter day for those who struggle with the illness of addiction. God bless you.
Thank you, Congressman, and we certainly appreciate your federal work, your state work, but mostly your county work.
Let me thank all of you for the great job you do, and thank you for bringing this awareness.
So we're going to finish up. There was a question over here about continuing a formulary, and we're right at 5. So, sir, you have.
Yeah, I was just going to, and I can follow up with you offline. We had this in Franklin County, Ohio. We put in a consistency of formulary. I agree with the sheriff that if they're on a name brand and there's a generic available, that's fine. But for many of these drugs, there isn't a generic, or the formulation that they're taking is not available. There's a long-acting, but not in generic, etc. So we actually require our medical provider to keep a consistency of formulary if they come in already having a script in hand. But at the cost of probably an increase of 40% to our psychotropic drug films.
And we've done the same thing in our prison, but it does cost a lot. Yeah, and if you come in with a certain, you're working with an organization, and you're certainly, and you're already on a prescription formulary, we'll keep that going. So I know a couple of our panelists had to leave right on time to make flights. So we'll take one more question, and then we'll ask you to keep in touch with us. Yes, ma'am.
I was going to clarify, as a pharmacist, you were talking about generic substitution, and that is totally different from therapeutic substitution, because the drugs may be in the same class, but they're different drugs. And formularies talk about therapeutic substitution. So they are totally different drugs, and that explains exactly why we need to have these people not lose their Medicaid, because then they won't lose the drug because the formulary will already cover it.
Good point. Well, thanks, everybody. Keep in touch with us. Keep looking for information. Thank you all for being here.